Okay, so I'm going to start off by, we did the introductions and stuff, but this is who I am, okay? Love basketball, love the Phoenix Suns, and hate them at the same time. They're giving me best and the worst memories because they always lose. And my kiddo, right? That's my contribution to the world. One spoiled, stupid kid. I told him to go, huh? Oh, I do say to him. Oh, no. Always he knows I tell him. That's what I said. And again, and it's simple thing. I'm like, just go to Perio. You can just walk right in. You don't have to do anything. He's like, no. I want to do something different. His mom's like, oh, go to medicine. Like, no. Don't want to do that stuff either. So this is where we are. This is a trip. This was about 8 years ago. We took a week off and we traveled with the Suns wherever they went. So first stop was in Detroit. Nobody wants to go to Detroit, so we went to Chicago. Then we just flew in for the game, watched them lose, then went to Miami. Watched them lose, went to Boston. Booker scored 70 points. That was great, but they lost. And then we went to Brooklyn and watched the game there, and they lost again. Again, they lost every single game, but memories still are there. We still talk about it. It's the best trip we ever took because it was me and him in one-on-one, and we can, bond over there. And I think that's if any young parent could have a kid, if there are multiple kids, go one-on-one with them because then they feel the most important thing. And so that would be my little advice as family with your kids to do that. All right. So the other thing is I'm a periodontist, as I explained. I love what I do. This profession has given me insane lifestyle that I never thought I would have. We came here as immigrants. My parents worked their asses off. We had an amazing family. I've seen Josefa born, Owesi, when he was young, he would come over here. We would spend time together. Amazing family, amazing community we have. And this profession has given me an amazing life that I appreciate. Where's that? Press it down.
Oh, there you go. Got it.
Okay.
It's down.
All right. So periodontal disease. Okay, we go through dental school. We all go through all the different paradigms, and this is periodontal disease. These are numbers. Numbers do not lie. They do not have feelings. All right. This is every one of our practices. 4 out of 10 adults in the U.S. have periodontal disease. None of us live in any magical community where they will not have that number. They might go up and down a little bit, but not a lot, right? And out of that, 1 out of 10 people in the age 30 and above have severe periodontal disease, right? That's just numbers. And if you go age 65 above, it goes even higher to 6 out of 10 people. So these patients are in our practice every single day. Not a perio practice, not a GP practice, every practice. Right? So this is the most common thing we have. Well, going back. Nope. That would be great. I would love it. That's your dental school dream. Okay. So these are periodontal disease is one of the diseases that we have that connects us to our colleagues next door. They don't think somehow the mouth is not connected to the body, right? But we know having periodontal disease increases the risk of heart disease, lung, diabetes, Alzheimer's. And for women with pregnancy, preterm low birth weight kids. So these are connected, the body is connected. Yet we do not diagnose or treat periodontal disease as much as we should. I had a conversation with one of our dentists, local dentists, and I go, what's the disconnect between perio and dentistry? And he goes, us restorative dentists, we're very comfortable treating hard tissue. When it comes to soft tissue, we don't know how to treat it. So we're afraid of it. And I thought, and that gave me, I'm like, wow, that's a failure from my generation when we were teaching in schools and stuff to teach that part. Because we get them into cutting crown preps, doing veneers, doing endo, but periodontal disease is kind of glanced over.
Intentional, right? Just like ortho.
I don't know if it's intentional. I don't know if it's, ortho I think is intentional. I agree with you on that part. But perio, I think they just want to go cut things, right? They want to cut teeth. They want to prep teeth. And so they think of perio as a prison where a patient goes into periodontal therapy, they're not going to come out for a year, right? And then they'll be about to graduate. So they kind of skip over that. That's my belief system. I could be wrong, but that's what I think. And that's what I felt with my dental school education. I did not get enough perio training. When I went to perio, within the summer, I realized, oh my God, I have no clue about dentistry. I have zero idea what dentistry is. Now, these are the methods we use for diagnosing, right? We take an FMX, we take panel, we take CBCT, we do probings, we do pictures, some use loops, some don't. These are the basic things we do. I can't diagnose perio from Panorax or decay. I can diagnose pathology, but CBCT a little bit better, but my go-to is FMX. All right. Then what does a comprehensive exam include in perio? So we're doing risk assessment, right? Do they have diabetes? Do they smoke or not? Family history of diabetes. Do they have, then you do intraoral, extraoral exam, periodontal probing, occlusion. I am massive on the occlusion. There's not a single periodontal patient in my practice that I will not check occlusion on. And then going back to orthodontists, I think they're fake dentists. They're not real dentists. They never check the bite. All they want is straight teeth. But I may be jealous too because they don't do shit either. So kind of mixed in feelings on that one. Thank God. No orthodontists, right? No. Are there any ortho Boris? No, right? Oh, that's what.
Do you know any? I'm sure there must be. They're not part of we don't come to the Jamaat. You're right. Yeah.
Okay. All right. Mobility as well, right? Now there's actually a really cool new toy that came out that checks the mobility of teeth and implants. You see the implants integrated. On teeth, it gives you a number so you can track it over time. So if things are getting good or bad kind of deal on there. And I love that. It's a toys. I love toys.
What's it called?
Tooth checker? I don't know. You're asking me technical stuff. I'm a picture guy. Full set of x-rays, all right? Photos, I will not go, if I have a new patient, the protocol is when they come in, my TC will go in, do a patient interview. That interview means medical history, dental history, take a full set of x-rays and pictures. When I come into the room to do the exam, I want the picture to be facing the patient on a 55-inch 4K TV. I want them to see all the crud they have in their mouth because I want them to own the disease because we don't own the disease. And then and home care as well, evaluation. This is my little thing, probe every patient every time, right? The most important thing we do for our patients is doing the exam. If the other things are mechanical, we can teach anybody to do it. But if you do not collect diagnostic data, we do not diagnose and treatment plan, those are things that make us doctors. Not doing the work. There's lab technicians who can do crown prep a lot better than I could, right? But this, I don't think they can do that as better than I can. Mobility. This is super important for periodontal exams. When you're doing exam, that tells you a lot of things about tooth health. It tells you about the occlusion. It tells you if there is discrepancy in the lateral forces, and so every tooth gets it to check the mobility of the tooth. Fremitus. What is fremitus? Fremitus basically, you have the patient bite down, put your fingers on their teeth and see if it moves or not. If it moves, you have to adjust it because what that's telling you, they are prematurely hitting on those teeth or there's something going on that you need to be aware of. If there is full mouth, I mean, there's fremitus everywhere because the bite is off. They might need ortho. You might need to have night guards. You got to do something for them. But it gives you information. Occlusal trauma. Occlusal trauma does not cause periodontal disease. But if you have occlusal trauma, is going to make it worse. It's going to accelerate bone loss and accelerate the tooth loss on those patients. So that's what we have to be aware of. Again, bioequilibrium and a night guard. Again, as I said, I do not do periodontal treatment without occlusal adjustment. There's always some sort of trauma there. Again, a lot of our kids get braces done. Orthodontists, again, I was making fun of them, but they're amazing doctors. They're good at getting things aligned straight, but it's hard to go up and down because it's hard moments to do, and you have to do the bite equilibration, but a lot of them don't do it because they do not have a handpiece in their practice.
Is it like, can I ask questions when you?
100%.
You know, who does this occlusal equilibration? Does your GP do it? Do you send it out to him, and are you making sure he does it? Do you see
I do it. If it's in my chair, it's more efficient and for time and to get it done, I do it. Because I deal with 160 referring doctors. There's different skill levels. There are some people like, if it's a prosthodontist, even I've communicated with them, hey, if this is the case, I'll do it. If they've done a full mouth rehab, most of the prosthodontists won't do a full mouth rehab before they get period clearance. But then, we'll keep a check on those things.
And you get a night guard made by the GP?
Yes, I prefer it to be made by GPs, but if again, with certain offices, I have an understanding that they're like, no, just go ahead and do it. So,
What kind of night guard do you give them?
hard night guard.
Do you have an arch preference?
I like the mandibular, but that just preference. I have no reason or rhyme or reason one or the other. If somebody had already had a night guard before, and then I ask them which one was it, then I kind of stay in the same arch. But yeah, please ask questions. This is way more fun that way. Open contact, same thing, right? If you have open contact, it's a place for food impaction. It's going to increase probing depth. It's going to increase recurrence of decay or decay. Also, if you have implants, there are studies out that says posterior implants, teeth shift, the open contact, it gets an open contact, and food will get impacted in there. You'll start getting bone loss on the implants. You'll start getting decay on the adjacent teeth. This is partially the implant, partially facial growth. And there's a bunch of different studies out there. Jose Fabai, they're way better at those studies than I am. I'm very practical. I want to get shit done, and what this information, what can I do with it, right? But I want to be aware of it. Facial growth, this is something we learned in implant dentistry, that we were getting discrepancies, especially in younger kids who had 20-year-old, their implants done. And then 20 years later, you see the incisal edges changing on the 8 and 9. And we realized what the hell is going on. The implant didn't move, but the facial bone growth changed. Again, we talked about night guard, same thing. This is my practice. Every patient gets a full mouth x-rays, and every 3 to 5 years, depending on how their disease risk factors are, we'll retake them every 3 to 5 years. If I do not have this, I cannot diagnose. I don't know what's going on. And they don't come, I don't feel people come to my practice to get their teeth clean. They come here for oral health. We want to keep them healthy. If we do not do these things, how do we keep them healthy, right? And how much does it cost? This digital X-ray costs us nothing. It costs us 20 minutes of assistance time, but it saves the patients. We can keep them healthy and keep them better that way.
Do you ever get pushback on patients, not for the cost, but for radiation and exposure?
I really make fun of them. I go, do you fly?
Yeah.
Yeah.
Yeah. Do you get a lot of that pushback? Or?
You do, but I just make fun of them. I make them feel so bad. They go, okay, fine, take it. Just stop harassing me. I mean, one of the things, and this is my little things right now, the new ADA guidelines are, you don't need to have a lead apron. If I found that if we took the lead apron out, they're like, oh my God, why don't you have a lead apron on? So I just, yeah, exactly. I just put them on just because we already have it. I'm not buying any more, but I use it. We just recently, I was always against the Nomad. I don't know why in my head I was against it, but I finally got a couple of them, and my freaking assistant love it. And when they do it, my patients don't get that. I don't think patients they say, oh, they're in here taking it with me, so it can't be that bad. So it's different, and it's really easy for them to use. And if anybody wants to do it, Woodpecker has one. for freaking $2,400.
Even Vatek recently bought.
Yeah, that's Woodpecker brand. Yeah. They're huh? Woodpecker, same. Yeah. Portable X-ray. Yeah, handheld. $2,400. The electric handpieces from that company, $350. They're better than my freaking NSK ones. And they haven't broken. I've had it for a year.
They get hot though.
The Woodpecker one?
I have tried, not the electric. So I personally don't like electric. I have both. Anyways, I don't hijack your presentation.
No. Go. This is.
Some of the Woodpecker stuff.
Yeah.
I mean, it's just a personal.
Yeah.
I've tried some of the Woodpecker stuff, like the AMS.
Yeah. Yeah. The
Biofilm.
the bio. We have the air polisher.
Yeah.
Yeah, I have the regular handpieces, which are $80. I don't even know when they got out. Probably throw them away. The electric handpieces have been great. I love electric handpieces. Come on. All right. This is my pet peeve. Vertical versus horizontal bite wings. I do not understand why people take horizontal bite wings. Vertical bite wings gives you more information. It takes the same amount of energy and time. It gives you the bone levels. You can see more. Just my pet peeve. No rhyme or reason. I'm sure somebody's done studies on it. Vertical bite wings.
I guess we see the distal of the canine.
Take another one. It doesn't cost any more. Right? It doesn't. I don't know, Zippo, what's your preference?
Vertical all the way, but my assistants say that the sensors are oftentimes oriented for a horizontal bite wing where the wire comes out, so taking the vertical is a bit more challenging.
I don't care about them. Huh? Yeah.
They're just too, shit came out with them, right?
Yeah. All right. Can anybody tell me what's wrong with this PA?
Angulation.
Okay, what else? Huh? That's the main thing. You do not see the apices, right? It's not undiagnostic. This is junk. If my assistant takes this X-ray, I come in, I literally turn around, walk out. If my X-rays are not perfect, I will walk out. The only problem is a lot of times I have patients who are referred to us with a full set of X-rays. Then I'm like, oh, okay, fine. Do we see cement on this implant crown? On that angle, you can't. But you change the angle, you can see it. Right? So angles matter. These things matter. Right? Again, if you took the X-ray and you go, oh, yeah, that looks good, that comes back a few years later, and then bone will be gone. You see this much X-ray. It's ton underneath there. There's tons. That's just what shows up. You know, everybody does implants here, right? Everyone, yeah. We all see it, right? If something's going wrong, we open it up. It's tons of crap underneath there.
Do you see cement retained crowns? A lot of them nowadays, or it's all screw retained?
I deal with 160 people. I see.
Just, cement retained crowns are just going out.
Especially with the angle screw channels and everything, it should be, but it's not. Because it's habits. It's hard to change people's habits. I've done it for this long. This is what it is. This is how we do it. Right. I mean, I literally give my referring doctors a milled custom abutment with models on it. All they need is a shade guide and tell the lab make a screw retained crown. And it still doesn't happen. All right. So how do we identify diseases in perio, right? We go, oh, you have a little bit of bleeding, you have a little bit of bone loss, you have some gum gingivitis, or you might have a cavity, right? This is what we say. I do not understand the word little. I've never heard somebody go, oh, you have a little bit of cancer, you have a little bit of high blood pressure, you have a little bit of diabetes. Now, if you go to, correct me if I'm wrong, with physicians, if you are getting borderline, with the cutoff for high blood pressure, you need to get this going, control that. Diabetes, same thing. Why do we do this in our profession? Why do we say, oh, it's just a little bit of bleeding, or a little bit of bone loss, or a little cavity? We'll watch it. We'll keep an eye on it. Because we don't want to tell the patient they have disease. That's why they literally came to see us. unless you think you're a tooth cleaning service and they come to get your their teeth cleaned. We're not. We're all healthcare providers. Right? All right. This, in the great wisdom of all the periodontists, this is the new naming system we have came up with. All right. There's good and bad thing in it. It's a little bit more complex, but it's very comprehensive. Right? It breaks it down. Before, like when I was in dental school, it was mild, moderate, severe, periodontal disease. Now we have stage and grade. And I like the system because what it does is, if you say somebody you have stage 2 cancer, they have an idea what that means, right? If you say you have a stage 2 periodontal disease, they understand what it means. Stage 4, they understand what that means, right? But the way I use this is simple. I break it up into 2 parts, stage 1 and 2, which would be older form, would be mild to early moderate. I go, if this is the case, what we need to do is clean the root surfaces out, right? If you clean the root surfaces out, we should be able to manage it, right? When it comes to stage 3 and 4, those are more severe cases, then it needs help. It needs some chemical warfare agents in there or a lightsaber of different color, depending on what you guys want to use, right? Periolace? No. What laser? Yeah, the periolace, right? Yeah, there's the biolace, periolace, and NDA-YAG, erbium lasers. And where you guys have lasers? What do you guys know what you guys are using?
We have both actually. Urban YAG and we have CO2.
Yep. And those, anybody else have lasers?
I have the ND and
Erbium, yeah, for Tana, right. And I think if I had to buy it again, that's what I would buy because it has both the wavelengths in it. Right, I agree with that, right? And then this is grade, goes to severity, this puts in if you have patients are smoke or not, they have diabetes or not, if they have they lost recent bone loss in the last few years, so it puts in a different parameter that way. And again, this makes it simple, but I think with a lot of, I don't know how many periodontists actually use this, and even fewer general dentists use it, right? But this is the way we have to diagnose in our charts. This is how we're treating periodontal disease, right? We talked about earlier, right? It's a blind procedure. I don't think you guys do anything else blind in your practice, right? None. I remember still in dental school, you'll be scaling and they'll be like, oh, put your finger on it. Can you feel the bump? I had no freaking idea what that meant. Still don't understand that part. But that's what we do, because that's what we have had. So why do we do gum surgery? Because we need access. We need to see what's underneath the gums so we can clean it out, right? That's the only reason we do a flap, to see. Oh, come on, you can do it. No? Okay. All right. So this is what we do the deep cleaning. So we do deep cleaning that we're doing blindly. It doesn't work, then we go do surgery because we know that's going to work to get the stuff cleaned out. So why is surgery necessary? One word. We need to see. That's the only reason we do surgery. Right? So this is the data from 70s. And if you go further back, there's more data that shows the same thing. When you're doing SRP, if it's less than 3 millimeters, you're going to be pretty good. You get an 83 on it, 83%. If it's 3 to 5 millimeters, you're at about 40%. And if you're 5 millimeters, good luck. You're not touching it. And that's not because you're not good at it. It's just because the instruments are not made to go that deep. It's just not, right? And when these studies were done, they would spend 30 minutes on a single rooted teeth. In our practice, most restorative practices, more perio practice, is anywhere from 45 minutes to an hour for a quadrant. They spend 30 minutes per tooth to do this. And this is how good they were. And we'll come back to this slide a little bit later. All right, you want to go? Thank you. So why is visibility important? Because if you can see it, you can treat it. I got this line from my neighbor in Laguna. He was a retired dentist. And when I was talking to him, he goes, yeah, if you can see it, you can treat the problem. If you can't see it, you can't treat it, right? In medicine, we do crazy things to be able to see. Same thing right now, right? We have cone beams, we have, intraoral scanners, everything, so we can see, so we can do this stuff. Oh, go back. Okay. This is another thing. Every modality of treatment, the key is, the reason we do it is to get the root surface clean, right? Everything we do is to get the root surface clean, because if you get, next, and if you cannot get the root surface clean, it doesn't matter what you do, it will not work. You can use any bone growth factor, you can use any laser. If you have calculus on there, it will not work. Nobody can prove me any other way. And I do not need a study for that, because we know it, right? We have the lasers. The reason I got a laser when I initially started about 2011, and I put it away after a year, because every time the results were not what I wanted. What I would see when I flapped it open was calculus. And I knew if I can't get the calculus off, it won't respond. But if you can get it off, it will respond, but not if you don't get it off. Oops, sorry. All right, so this is a case, again, I'm going to show you a bunch of cases now, all right? So this is a case where we had, back in a while ago, about 10, 12 years ago, maybe longer, patient came in, the main complaint was teeth had moved. And when you take a PA, there's vertical bone loss, probing, and then about 5 millimeter probing depth. So we treated with skin and root planing. The hygienist, she spent literally an hour on that one tooth. And she got that to improve. And we can see it over time, right? It has improved. And this is what we started with. This is next year. And it works, right? But if you get the root surface clean, it works. Now, sorry guys. So this is before and after. So now, when this is pathologic migration. The reason the teeth moved, because there was infection in there, bone loss, teeth moved. And about 20% of the time when you get it cleaned up, it closes the diastema, but I never tell the patient that it's going to close. If you go, we might get lucky, we might not, I'm not sure. So this is back in the day, again, this is from about 2010, 2011. Patient came in, vertical defect. We open it up, bunch of junk in there. We clean it out, and you get a new bridge, and it looks pretty again. But that was the way we could treat them predictably that time. I could treat them at that time. I didn't have a better way of treating them. So now going back to this study, I want to go, if we were back in dental school, if you got an 83, you would have passed. If you got 39 or 11, they're like, you better need to find a different profession. This is not for you guys. But yet, we still do this. I do not comprehend this. We're evidence-based profession. We do based on what evidence says. We have evidence that tells us it doesn't work, but we still keep doing it, right? And I don't get it why. So this is where we're trying to change. We are doing SRP, which we know doesn't work, to then end up going and doing surgery that we know patients don't want to do it. Yesterday, I had a great conversation. Salim Uncle, I'm sorry, I'm going to throw you under the bus here, okay? Salim Uncle Motiwala, we're talking, and he goes, Tasneem Ben had this surgery. They went and cut and moved the gums over his jawbrow all down, and she was miserable, she hurt, and I go, no, there's other ways of doing it. Then he goes, why does Mufaddal was sitting there? Why doesn't Mufaddal have it? Does Mufaddal have it? I'm like, no. He goes, why he doesn't have it? I'm like, go ask him. Am I right or wrong? All right? Because patients who've had it once never want to do it again, right? So this is what we're trying to change. Something that we know doesn't work, then we go do something the patient doesn't want to do. I'm sorry, guys. All right, so this is where I'm going to go to, the dental endoscope. This is the progression of endoscope. This unit right here came out in the 1990s, early 92, 93, made by some engineers. introduced at the AAP. There was a hygienist, Gail. She's actually out in Malibu. She's 80-year-old. She's amazing. She's the one who perfected how the techniques and how to use it. And she still practices, she still uses it. Now this one, other ones. This came out in 2006. This is what I got in 2012. And my practice was based on this technology. It's amazing. It works great. Love it. Only problem is the company doesn't sell it anymore. Zest owns it, and they've gone into the teeth killing business, not teeth saving business. So they literally killed it. And then this is the product we came up with in about a couple of years ago. So, but they look about the same stuff, but this is the visual difference. This is from 1990s. That's what you look under for a cavity. That's what it looked like. 2006 looked like that, and now it looks like this. So this is the progression in the resolution of the product. So what is basically done on endoscopy? There are different components to it. There is, can you go back? Okay. There is a camera, which is a digital camera. It's 1 millimeter in diameter with fiber optic lights around it. It goes in a sheet that protects the fiber from the oral cavity and the cavitron when you go in. Because that fiber is delicate, if a cavitron were to hit it, it would destroy it. So this kind of protects it from the saliva and blood and from the cavitron tip of the tip. And this is where it goes inside and to reflect the tissue back. And these are 4 different angles, just like our Gracie curettes, the buccal, lingual, mesial, distal. So you kind of change them out as you're using it. Next one. This is what it looks like in the mouth. So right, this is the, again, I do not know how to use it. My hygienist uses it. It goes in the mouth. It goes between the tooth and the gum and goes inside the sulcus. So you can see it. Sorry. Oh, you're doing it? Okay, go. All right. So what you're basically looking at it right here is the enamel, then the root surface, the calculus, the tissue, and this is the tip of the explorer pushing the tissue back. Go. Next. This is the hygienist using, there's a video on there, can you play it? So she's looking at the screen, it's in the mouth, she's using both her hands, one with the camera, the other with the cavitron, and you can see what's going on the screen, and she's cleaning it out. She's not going like this. Every stroke is meant to get something off. So ergonomically, they're sitting straight, they're not looking down, and they're going that way, straight at the screen that way. So what do you see? We see calculus underneath the root surface, fractures, overhangs, subgingival decay, gutta percha, external root resorption, excess cement, cemental tears, different root anatomy, and CEPs. So these are all the things we can see below the gums, and majority of them we can treat it. This is the other thing I want to change. Like, there's a conception, oh, this is replacing SRP. I disagree with it. This is a minimally invasive way of treating gum disease. And I want to go back to our medical professions. When they're doing, if they have a clogged artery and they're using an endoscope to go clean it out, they do not call it non-surgical. They call it minimally invasive. Why are we demeaning what we do to our patients? Because when we say non-surgical, they're thinking, oh, why did, what the cost doesn't justify it then. So to me, it's minimally invasive procedure or surgery, either way you want to use it. This is the study that was done, that published in 2004 in Journal Perio. It compared endoscopic debridement to a open flap surgery. Now in this study, they did not use any chemical warfare agents, meaning Emdogain, Gem21, or bone graft, or any laser. They just flapped it, cleaned it out, or they used a scope and cleaned it out. And what they found, the difference was everything in periodontics is 2 millimeters. So they found it was 2 millimeter improvement, didn't matter which one you did it. But what the other conclusion was a lot less discomfort with the endoscope than opening up flap. And again, I don't need a study to say that. We all know if you cut the patient open as opposed to not, if you do it without opening up, it'd be less painful. But that's what we have. All right, let's see a few more videos over here just to see what we're looking at. This is again, tooth, root, calculus, tissue, the shield back there. So this is real-time speed. It's not speeded up or anything else. They're just going in, cleaning everything out.
Patient obviously is getting done.
Yes, yes. It just, it's so much easier.
Yeah.
And afterwards, I have them take an Advil or Tylenol, just makes me feel better.
Yeah.
But the next 99% of the time, they didn't need anything after that.
Yeah.
That's a Cabochon chip you're saying?
Yes. In my practice, we have both Cavitron tip and a piezo. Yeah, and I think now I have 6 hygienists in my practice. And they're trying to shift towards the piezo because there are a couple of different tips which are longer, and the ball-shaped tip with the diamond coating is beautiful. The only problem with that tip is do not use it blindly because it will gouge the root surface because you don't know what you're looking at. All right, so again, is caked over everywhere, right?
Can you use this to clean around implants too then?
It's coming up. So let's go. I think time-wise, let's.
Next one?
Yep, next one. This is an implant. So this is excess cement under the implant.
Is all this recorded through the Periodontal?
You can take recorded or you can take pictures for sending it out to insurance.
Yeah.
I take pictures a lot of times of subgingival decay or open margins, so sending out to referring doctors.
Yeah.
I don't know, they're saying that you can use a Cabochon on an implant like that? Like, is it okay?
I have arguments. There's a gentleman, George Kakakis in New Jersey, and we have had a little go at it about this, and we have fun about it. But he's like, no, this is leave titanium, particles in the tissue, and it'll cause problems and stuff. I'm like, do I want to leave calculus behind, or cement behind, or leave, titanium particles behind? And he's like, well, and he has some plastic and titanium instruments, but I'm like, plastic instrument does shit. It doesn't touch anything, right? And the titanium instrument, he has some beautifully designed. It'll work great at the margins, but if you go below, it's hard to get in there. So he's actually going to come to my practice in March, and we're going to work on some cases together.
The European YAG removes all this.
Let's have a bet. All right?
It does.
No, let's have a bet. You do it blindly, and then we'll go look.
Wait, this talk is about blindly or talk is about which instrument to use, right? I'm just saying.
No, instrument you can use. You can guess. If you open it up, you can do it 100%. If you cut the patient open, you can see it. Then you can do whatever, again, whichever lightsaber you want to use, whichever chemicals you want to use, it'll work. But if you want to do it, when you're using Erbium, are you opening up the flap or not?
It depends.
So how do you decide which one opens up, which one doesn't?
The European YAG, I can sometimes just decontaminate,
Okay.
and I can create, with the ND YAG, I sometimes create that brownish red blood clot.
Okay.
So I have, different modalities of how I want to treat.
I understand. How do you know you've decontaminated every area, taken everything off?
And I also flap it. That's what I'm saying. It's what the patient needs. You can't,
If they have, okay, so is it, if you have 4 or 5 millimeter pocket, then you will decontaminate it, or if it's above that, then you flap it. What is your criteria when you cut off?
my patient. I'm not referral to his practice. So I'm saying if it's a periimplantitis, something that it's my patient, then
Yeah.
I'm going to stick my neck out and treat it.
No, no.
Treat, right?
Yeah.
So I know when the implant was placed, I would probably know what's causing it. So I have developed my,
What I'm saying, where's the protocol? How do you decide which way to go?
so it depends on whether am I ever going to take this implant out, how
Okay.
severe. Sometimes I've placed implants 10, 11 years ago. They've left my practice. They come back, there's a new dentist who's going to do something. So now they're coming back to me saying, I live 30 miles away, but my new general dentist is saying, go back to the person who
Yeah.
placed it. So now they've come back to my practice.
Yeah.
You see?
Yep.
And I take my CT, I look at the bone loss, and I make a decision, how am I going to treat this patient?
Okay.
Because sometimes there's no mobility.
So,
We have probing depth and a GP referred them. So I will not really give you an exact, because for me, it's as a GP, more of what I'm going to do with this patient who's only come to me for this one day and doesn't think I'm a specialist and doesn't want to spend thousands of, people. Somebody comes to you, they are ready to spend. I don't want to hijack your talk again.
no, I'm complete. This is good. I love this. No. But go ahead. So,
So I have my, I look at it, the first appointment day, they just come to me out of the blue. I'm looking at it now, okay, well, I haven't seen you, I don't know going on. Yes, many times I flapped it.
Okay.
But
Yeah.
I found the erbium gag.
It decontaminates. Yes, it decontaminates. I agree with you on that 100%. It decontaminates. My only argument is if you can see it, right? I mean, to me, in implant, when the guys are lecturing and everything else, it's always funny. Whenever implant is periimplantitis, if the implant they did, they'll try to save it. If somebody else did it, they take it out and restart over again. That sounds right? It's just funny, but I'm like, if you're really treating the patient, it should not matter who did or didn't do it, right? We should treat the patient, everybody was the best treatment for them or given the best option for them. But it's just human nature. I do the same, I do it, he does it, everybody does it. We all do it, right? Nothing there, but that's what it is. So this, again, another patient, this came in, gentleman, his main concern was, hey, my teeth are moving, right? We looked at this, and again, if this is in majority of practices, we either gonna go, okay, we do periodontal surgery, clean it up, then get ortho to close up the space. 2, take it out, get ortho, then do an implant or a bridge. Or 3, take it out and do a bridge or an implant with the open gaps in there. That would be the normal protocol on there. Where do we go? I gotta go backwards? Yeah. Okay. So this is what we treated. This is 5 years later. The tooth is still in there. He doesn't care the way it looks. He just wants to save the tooth. And it's inexpensive, and it did not hurt the patient. So we can save the tooth still on there. Again, this is 6 years worth of time on there. It's stable, it's healthy. I'll do it every day. My right now, my motto in my practice was modern periodontics. I changed it about 4 years ago. We save smiles. That's what I want to do. I do stupid amount of implants, and I'd rather not do one ever again. I'd rather do perio, CT graft, crown lengthening, way more satisfying, way better way of doing things. This is what it looks like, right? Here's a 35-year-old patient. This is what she came in. She had gone to 3 other dentists. They all were extractions, hybrid or extractions, dentures. This next one, this is the x-rays. And again, I don't blame any of those treatment plans. I can understand the treatment plan. She's 35-year-old, she has aggressive periodontal disease, and she has pathologic migration everywhere. This is what, again, majority of us would do, and nothing wrong with it. This was treated with a blue laser, and this is afterwards. This is what we did. I have a perio laser. That's what we debrided it, cleaned it out. This is what we treated it. Before and after, side close-up view. Send it to orthodontist. This is what she looks like. Right? Without cutting open the patient, without losing any teeth. She's 35 years old. We do not, if you do a hybrid, we have to chop down half their jaw. You make them a dental cripple for life. Do I do it? Yes, but I pick and choose my cases.
Do you do any NDA afterwards, after you've done your
100%. Yes, I use my lifesaver. Yes.
So your hygienist does the probe, and then you do the NDA.
Yes. Yes. Or I use biologic growth factors like Emdogain or Gem 21.
What are you using that?
Yep. Because Delta Dental will not cover the lifesaver. I'm sorry, you call it lifesaver because that's what my friends call it. This is a patient. She's 88 years old. She was referred to my practice by one of my really good referring doctor, and he's like, hey, the bottom teeth are really bad. We got to take them out. And then if you can do 2 implants in 23, 26, and do a bridge there. And I go to her, and she's 88 years old. She could kick my ass with her left hand. And she goes, there's no freaking way of taking my teeth out. I just lost my husband. I'm no mood to do this shit. All right, what else can you do? I do not want to go through all this stuff. I'm like, this is what the x-ray looked like. Next. And where we were thinking there might be a fracture on their incisor, right? And I'm like, hey, we'll try, see what happens. No guarantees because there's generalized periodontal disease everywhere. we'll just buy time, right? We go in there, there's no fracture. It was just junk built up underneath the tooth. And that's what she looks like 3 years later still, right? Another vertical defect, right? Now, this is just debridement, this is just straight out debridement. Right here, we have vertical bone loss. Again, we still have vertical bone loss, but if you can see this crestal laminar dura coming back up, that is a sign of healthiness. If you have crestal laminar dura present on your x-ray, it means it's healthy. If it's not there, it doesn't mean it's not healthy. It could be either way. But if it's present, it means it's healthy, right? So that's what we want to get to. This is a cemental tear, okay? So what you have an implant, you have a tooth there, and there's a deep pocket depth over there. So again, the implant was done a long time ago, everything was healthy, came back, that's what it looked like. This is what came out of there. And when you get a microscopic study done, it was acellular cement. So it's a cemental tear. Here's another one, same thing, right? Go, play the video. So you can see right here, that's what it looks like. So you go in there, and again, normally this would have been done, flap the patient open, and then do it. If you put any regenerative material on there or lightsaber on there, it would not have, unless you get it off, it won't work. Nice.
Is it zooming in or?
Yeah. No, it's just in and out. In and out of that thing.
The camera does not have a zoom.
It does not have a zoom. It is 100x magnification. Okay, so that is set at one setting. Yep.
So these guys really market this to the general dentist.
Yeah.
They or the hygienists are just using, they don't have an NDI. They're only doing an enhanced SRP with this.
Minimally invasive procedure, yes. They can use biologic material. You can use Emdogain Gem 21. You can place it inside with that if you don't have a laser.
The same day?
Same day, same time. You debride the root surface and place the regenerative material underneath there. So regenerative materials, there's two materials which are most commonly available for us. It's Emdogain. It is sold by Straumann. It is a, what is it? Thank you. Again, I just put the shit in there. The studies have shown it helps improve tissue growth, tissue healing. I don't think there's a lot of studies on bone regeneration. Some people swear by it. I think periodontists love it. I was not a big believer in it. I started using it because Delta would not reimburse me for my laser light, so that's why I started using. The other one is Gem 21, is a PGF growth factor. I think I love that material. Okay, it costs more than Gem 21. Than Emdogain, but I think it works a lot better. I use it for vertical defect and calcifications. If it's a Delta patient and they have horizontal bone loss, I'll use Emdogain because I need to get reimbursed.
You basically debride and then you put that in there like kind of like a
So what like something like a resin. So what I do is it comes with a cannula. I change the cannula out with the the etchant tip. It goes right on it, so it's not tiny little tip. I go in deep in the sulcus and walk around it, and apply it in there.
So is it like a liquid powder? Or what is
Liquid,
it?
yeah, gel liquid kind of. Don't eat for half an hour, then go back to normal. Because there's no cutting. I'm not worried about wound healing or anything else because they're going to do it. And again, all these patients are going to occlusal adjustment on there, except for one is severely, the other lady that was kind of crazy because I'm like, I don't even know where to begin. So that she went to ortho afterwards. All right, so dental endoscope. Normally, with the hygienists in a dental practice, they're making about $150 an hour. They're producing that much around there in their practice, right? With that dental endoscope, if you're doing this minimally invasive procedure, you can bill out for they can make about $800 an hour. This is the math on the economics on this end. So in a regular practice, a hygienist should be producing about $5,000 a week. by adding just one patient, doing 4 quarters of therapy, that's $3,200. You're going to increase your monthly production by about $12,000. Basically, you're going to pay this off in 3 months. Go back. This is the gentleman I always want to give credit to. This is the gentleman who had the other scope company before when I bought it. He helped us, he trained us, and he's just passing the baton. He's retired skiing in Idaho. Now I'm doing the work. But I always want to thank Dr. Kwan for that. All right. Thank you. Any other questions or concerns? No? Cool. Thank you.